Welcome everybody again to the EPI-WIN webinar. We're once again very delighted to have Martin with us here today. We also have our colleague Maria joining us. She's just been caught up in a meeting with our senior management, but will be on her way very shortly. So I invite you again. We've received quite a few questions in advance of this webinar, so we will try and address some of those towards the end. But again, if you do have some questions and we have time, please do feel free to input your questions into the Q&A function in Zoom. Once again, as always, we are streaming this to YouTube, so the recording can be found on YouTube afterwards, and we will be sharing the slides with everybody that has registered. I also have my colleague Judith on the line, who is the mastermind behind the slides, and Judith will be answering some of the questions live in the background. So welcome, Judith. And we also have Tazara, who is doing simultaneous interpretation into French. So you should be able to find that as well if you've joined from Zoom. So welcome to everybody. And without further ado, I'm going to hand over to Martin, who's going to give the first part of the presentation. So Martin, thank you so much once again.
Thank you very much, Sarah. I'm going to share my screen and let's get into the presentation. So, can you see the screen, Sarah?
Yes, we can. All good.
Okay, right. Let me just move some stuff around here. Okay, so good morning, good afternoon, good evening, everybody. I saw for some of you it's midnight or past midnight, so really great that you're able to join us. I hope you find this interesting. Let's get straight into this update on COVID vaccines and the immune response. And as with last time, we're going to begin with a very brief recap of where we are with the epidemiological situation. So unfortunately, as you can see, we've already had over 116 million cases. There have been over 2.5 million deaths. I find this really scary because I feel as if the last talk that I gave in this series was only a short while ago, and then we were at 2 million deaths. So that is scary. So I guess there's a little bit of good news. When you look at the bar graph that you see in the slide here, you can see that the numbers do appear to be coming down. But let's not get overconfident because we have previously seen numbers go down only to be followed by numbers going up again. And this is really being driven, as you can see, slight decrease in the European region and some decrease in the Americas. So that's where we stand today. The total number of deaths, as you can see in the black line, it's gone up. We're above 90,000 and coming down in the weekly rate. So again, let's not get overconfident that downtick is a strong signal yet. What I'm now going to get into is a discussion of the vaccines. And for those of you that have been on these before, you will see quite a lot of repetition. But for those of you that weren't, I'll try and walk you through the immunology and the types of vaccines that we're working with. So let's begin with this. I'm sorry, I've got to move some stuff off my screen. This is the first slide, is the immune response to the viral infection. So basic immunology here. There are two types of immune response. There's what we call the innate immunity. The innate means you're born with it. This responds to any infection, be it viral, be it bacterial. And this, if it works well, will prevent the virus or bacteria getting a foothold in you, and it will clear that infection straight away. Now, unfortunately, it doesn't always clear the infection. And so this is why we have what was called the adaptive immune response, where the body will develop an immunity that is adapted to that specific infection, be it bacterial or viral. And by adaptive, it means it learns to recognize that particular infection. So it will recognize a virus, and specifically it will recognize parts of the virus. So when you look at somebody that you know, how do you know that you know them? It's because of the shape of their nose, the color of their eyes, their hair. And it's a bit the same, our immune system. It will develop something that recognizes the pathogen, the same way that you recognize the people you know. So we've got, first of all, here the cellular response. We'll be talking about the T cell response and the B cell response. The B cell response, this is antibodies. You all know about antibodies. These are proteins that circulate in the body that will recognize the the outer shape of the pathogen or part of the pathogen. And the T cell response, the way T cells work, is they recognize when a cell has been infected with the pathogen, typically a virus, and will either kill the cell in which the virus is multiplying, which prevents the virus multiplying, or it will call other cells to help and secrete molecules which are called interferons. Interferon, by the word interfere shows you what it does. It interferes with the replication of viruses. So we're in this graph below, which I keep saying looks as if a child was scribbling. I think I drew this one. What we can see here, starting from the left, is what really happens. The moment you get infected, the innate immune response kicks in long before we can detect the virus. You can see the innate immune response going up, and then we can see the darker blue line. This is when we can start detecting the virus. So that line could represent the amount of virus we're detecting. Well, a short while after we start able to detect the virus, the innate immune system is in full blow, and then we start seeing the early antibody response beginning up. And the day before that, we start seeing the cellular response coming up. So it's cellular, then early antibody response, then late antibody response. Now, the cellular response will stay up for a while and then start coming down, but I do want to emphasize that for both the cellular response and the antibody response, there is normally memory, and that memory is important. We'll come towards the end of this talk about the difference between a single, some vaccines we talk about, you receive a single dose. Some of them you receive 2 doses, and these can both provide protection, but sometimes the memory provided by the second dose is longer than just a single dose, which is why for some vaccines we give 2 or sometimes even 3 doses. Most of the vaccines you get early in your childhood are given as 2 or 3 doses because that really gives you lifelong memory. So next slide is, again, my apologies, I've got all kinds of things coming up on the screen, so I can't even see my own screen. So this is the immune response now in a vaccinated person. So you've been vaccinated or you've been previously infected. And now what happens when you come in contact again with the virus, your adaptive immune, first of all, there'll be the innate immune system, which will immediately kick in, but the adaptive immune system will recognize that virus. So your antibodies will recognize the virus and start removing it. And at the same time, you're going to have T cells that recognize that are there, that increased in number because of the first immunization or the first infection. And these will very rapidly clear it. So what we see here in the graph is it shows that the virus amount, which you start seeing coming up on day 2, instead of becoming very high, in the presence of an existing immune response, it's going to be very low, and within a few days will be removed from the body. At the same time, you'll see the antibody response, which might have been coming down because it could be you were immunized weeks, months, even years ago. Suddenly, upon contact with the virus, you get what we call an anamnestic response. The body remembers, and suddenly you get this boost of the immunity. This can be from the circulating B cells or the B memory cells. And you see that our cellular response, which was always there, but quite low level, suddenly it picks up again instantaneously. Within hours of contact with the virus, the cellular response kicks in. So the difference between a viral infection in somebody who was immunized and not immunized is the speed of the response. If you're lucky, the antibody titers are going to be so high that the virus just will be removed from circulation instantaneously. But even if it's not removed from circulation, even if the antibody titers have declined, you've got memory, and that memory is what's really important. So let's move on now and start looking at how we induce an immune response with the vaccine. So essentially, what we aim to do with the vaccine is induce the same immunity as what happens when you get infected with the virus, but without requiring you to get infected with the virus. Because when you get infected with the virus, I don't need to say it, it can be unpleasant, it can even be very dangerous or fatal. So what we try to do is to do this safely. We elicit the immune response to train it, but without causing any harm to the body. So we inject, typically, we either inject a part of the virus that interests us. Now, this part, how can it be presented? We'll get to this in a moment. We can have just a piece of protein isolated from the virus. We can put that piece of protein in another virus. We can express that with nucleic acids. We'll get to all of that. We can kill the virus. But the main thing is that we present to the body a component of the virus or a part of the virus that's been killed in such a way as to induce antibodies. That's part of the adaptive immune response, and to produce a T cell response. We typically talk about here both the CD8 cytotoxic T cells, but also the CD4 T helper cells that will be necessary when you get an infection to call the other cells to the site to secrete interferon and control the viral production. So what we're going to go through now is to get into the various types of vaccines that we are currently using in our fight against this outbreak. So what we've got, these are the immunogens. So the immunogen is what is injected into the body to induce the immune response. And the immunogen will contain the relevant part of the antigen or the whole antigen. It can be the whole virus, and we'll get through this. Now, the choice of the immunogen depends on what type of immune response is induced or what we want induced, as well as safety, the development time, production time, the costs, and access. So for each of these vaccines we're going to go through now, they all induce slightly different breadth of immunity. They all induce slightly different types of immunity. And for each of them, there were driving parameters. For some of them, they could be produced quickly, but they cost more. Some of them could be produced quickly, but we couldn't make a lot of them. Some of them were produced more slowly, but we could make them, a lot of them. And some of them could be produced slowly and are going to be very cheap. So each of these vaccines that we discuss has got pros and cons. There is no perfect vaccine, at least not for COVID, unfortunately. What we're going to talk about are the inactivated viruses, viral subunits, the viral vectors, and the RNA vaccines. Now, generally, we talk about nucleic acid vaccines, which include both RNA and DNA. But for the moment, for COVID, we don't yet have the other type, the DNA vaccines. So we'll just talk about RNA vaccines. So quickly in this table, inactivated virus. This, by the word, the definition, it's a dead virus. We grow the virus, typically on mammalian cells. We take the virus out and we kill it. How do we kill it? We either add a chemical, typically for coronavirus, we add a chemical beta-propiolactone. This cleaves the RNA inside the cell. So when there's no more RNA inside the virus is by definition dead. But what it is good, it doesn't change the outside of the virus. Now, for some other inactivated viruses, we use, for example, formaldehyde or glutaraldehyde. This also kills the virus, but unfortunately, it also modifies the surface a little bit. The advantage of this is it induces a strong antibody response, so that's good. But the disadvantage is it doesn't really induce a cellular response. That is, unless we can make it induce some cellular response with a lot of adjuvant. And typically, it requires growing a large quantity of virus. Now, this, bear in mind, could be quite dangerous. In the middle of a pandemic, having a huge fermenter in your city growing live coronavirus, that's probably not dangerous. But when you've begun and maybe succeeded in clearing the virus from your population, you probably don't want to be having a big factory with a big tank full of wild-type live coronavirus. And so you can see the examples of this. We've got influenza, rabies, hepatitis A, but I'll also mention polio. And when we make the polio vaccine, the inactivated polio vaccine called IPV, this is a huge concern because if there was an explosion in that factory, we would be releasing wild-type poliovirus into the environment. And so everybody within a radius of several hundreds of kilometers around the factory has to be vaccinated against polio. So that's the advantages and disadvantages. Then we come to the viral subunits. So here we essentially administer to the body a protein which is derived from the pathogen. Now, for some vaccines, we will grow the pathogen like we did for the inactivated virus, and then add detergents and purify a single protein out, but increasingly we don't grow the virus. We will grow just the protein that we want on a mammalian tissue culture or even an insect cell tissue culture. You will have heard of people growing this in baculovirus tissue culture. This is insect cells. Now, the advantages of this is this might have fewer side effects than whole virus, so slightly less reactogenic. We've seen with some whole viruses some reactogenicity. But the problem is these purified proteins tend to be poorly immunogenic. So that's why we typically try and make them into what we call a virus-like particle, where they assemble together. And we generally, not always, but generally have to add an adjuvant. Now, these also take quite a long time to prepare. Then we come to the viral vectors. We'll get into this in a bit more detail in a moment. So the viral vector, what we do here is we take another virus, a virus which doesn't cause any sickness, for example, adenovirus, okay, or measles virus. And we put into that virus, which can infect a human, we put into it the gene coding for the protein, the subunit we've just spoken about. We can express in these adenoviruses, we can express, for example, the spike protein from the coronaviruses. We then inject this viral vector into the body, and it will behave like a virus. It goes into the cells, it infects the cells, and it presents now this protein in exactly the same way as if it had been a coronavirus infection. Whereas previously with the viral subunit, the problem is it doesn't really get into the cells. So it's not seen quite the same way as the body sees the virus. Now, this is a great methodology, except that we've got a number of problems. That, first of all, this viral vector, if there's immunity in the population to the viral vector, this really doesn't, it means that it doesn't work very well because you just make an immune response to the vector and you don't need to make an immune response to the part that's been added. And with some vectors, we have to add boosting with a different vector or with DNA or RNA and things like that. So Ebola is the best example where we used vesicular stomata virus. I'll get to that in a moment as the vector. For COVID, it's mainly talking about using adenovirus as the vector. And finally, and this is the new one really, is the nucleic acids. Now, we've been talking about using nucleic acid for vaccines since I was a young man. And so that's about 30 years ago, the first time we began talking about this. And for a long time, it didn't work. We were focusing on DNA, but the DNA has got to get into the nucleus of the cell. In the nucleus, it's got to get translated to mRNA. The mRNA has got to get out of the nucleus into the cytoplasm and then get expressed as a protein. So about 10 years ago, people realized, hey, we don't need to use DNA. We can just inject the RNA. And they inject the mRNA. M stands for messenger. It is the messenger RNA. This gets into the cell, and in the cell, it's treated just like any of the other mRNA. Your cell is full of mRNA all the time, producing the enzymes that you need to keep the cell alive. And the mRNA coding for now our COVID protein will simply be expressed and will be presented as if there was a virus growing inside the cell, and the body will see it just as if the cell was infected with a virus, except that there is no virus, so it is safe. So the disadvantages, well, we've said here, relatively low antibody response. That's not really the case anymore. We're getting pretty good antibody responses now. The disadvantages for the moment, it's a little bit thermolabile, meaning we've got to use very cold fridges. Even that we're beginning to address now. If I'd say there's any disadvantage for the moment, it's really we don't have a lot of historical experience, so we're still learning how these work. But it's a very exciting technology, and I think this is going to change the way we develop vaccines for many years to come. Let's get into these in a bit more detail. So the inactivated viruses. So here, this little red circle, you can see that's the virus, and inside it, we've got the RNA. Now, we've destroyed the RNA by adding beta-propiolactone. I just want to give you a little warning here. If you add insufficient beta-propiolactone, the virus will still be alive. If you add too much beta-propiolactone, you will destroy the RNA completely to single pieces of RNA. The trick is to get just enough beta-propiolactone so that you've got some small pieces of RNA left, because RNA is an adjuvant. RNA is an immunostimulant. over our millions of years of evolution, we've learned to recognize RNA, non-methylated DNA, as being foreign, as being belonging to a pathogen. And when a cell sees RNA, it will actually start calling other immune cells to help. So it is a self-adjuvanting type of vaccine. Now, the problem is these inactivated viruses can't get inside the cell, so they're not able to present, for those of you that are immunologists, on the MHC1 pathway because they're not in the cytoplasm. So they will basically just get phagocytosed and presented on MHC2. So we'll be able to get a T helper cell, but we are not able to induce a cytotoxic T lymphocyte or CD8 response. But they are great for making antibodies. And also for those of you interested in how we're going to expand our production capacity, what's lovely about inactivated vaccines, there is no intellectual property on these at all. We've been using these things since 1925. So, these are a great, easy way to produce things. But as I said, the challenge is, are you going to be running a risk once you've removed the virus from your population if you're still growing this? And as already said, good antibodies, but not great cell-mediated immunity. So now that's the inactivated viruses. There are currently 3 of them that are being used in populations, which we'll get to in a moment. And they induce good protection. Now, the viral subunit vaccines. So again, I think to repeat what I've said, the subunit vaccines use the antigen of the virus without any genetic material. So here what we've done is either we've grown the virus and purified the protein, or we've used what we call recombinant expression, where we put the gene for that protein into a cell, insect cell, mammalian cell. We grow that up in tissue culture, we purify it. That means we don't need to grow the virus up. Now, the advantage of these is when you inject these, you will induce antibodies, but typically when they're by themselves, it's not very good. We need to add an adjuvant, and even with an adjuvant, it's not good. What we like is that they form virus-like particles. They assemble into multimeric structures, which then become much more immunogenic. But because they can't get into the cell, they don't induce such a strong cytotoxic T lymphocyte response, a CD8 response, but they induce a good antibody response and a CD4 T helper response. And we sometimes add potent adjuvants to enhance the immune response. The examples of this, just a reminder, so hepatitis B, the hepatitis B vaccines are very good examples of this. The recent malaria vaccine, the shingles vaccine, increasingly we are making vaccines like this. Now, let's get to the viral vectored vaccines. We don't have any viral vectored vaccines that are widely used in the population, with the exception actually of the dengue, the recently introduced dengue vaccine, which is only used under specific conditions, which we could get to in the discussion if you want. What we do here is we use a non-coronavirus vector. So as I've said, it could be a measles virus, an adenovirus, and into the gene of that virus, we put a protein from coronavirus. And so the examples we use, adenovirus, measles virus, and for Ebola, we use vesicular stomatitis virus. Now, these viruses that we use, they can be replicating or non-replicating. For the moment, all of those that are being used for Ebola that are approved are non-replicating. It's just by chance because both are safe. The Ebola example, that was a replicating viral vector. Now, the non-replicating, what happens is the vector infects a cell. Once inside the cell, it starts producing the antigen that we want, in this case, the SARS-CoV-2 antigen, but it doesn't produce all of the other things that are necessary to make a whole virus, which will then infect the next cell. Now, in the replicating viruses, these have the full mechanism. Once they've infected the cell, not only do they produce the SARS-CoV-2 antigen, but they also produce the other proteins that are necessary to make a new virus. That virus then escapes from the cell and infects other cells. So you get possibly a stronger and longer lasting immune response. But we've seen that the non-replicating are very safe and also inducing very good immune responses. So what's good about this is the antigen is produced inside the cell, exactly the same way as if the cell was infected with the SARS-CoV-2 virus. And so it is seen by the immune system as if it was a full virus there, and you get you get antibodies, you get T helper cells and cytotoxic T cells. So a very good immune system. As I mentioned previously, though, we don't know if we can use these things repeatedly. So if we've given you, for example, let's say the Wuhan strain on an adenovirus 5, we don't know if we need to do a strain change in a few years' time. Would we be able to use the same adenovirus 5 and give you now a new strain, or would the antibodies that you've got to adenovirus 5 now prevent the next vaccine working? So that's an unknown, and we're watching this space very carefully. Now, my favorite, it's as a very exciting technology. I really cannot emphasize how exciting this is, are the RNA vaccines. Here, what's lovely is we just code for a piece of RNA. Instead of spending years making a purified protein, it only takes you a matter of weeks to make an RNA with the sequence that you want. But the problem is, if you inject the RNA naked like that, it will be destroyed within seconds in the body by the enzymes, the RNases that are present in the body. And also in a test tube, it's very unstable. So what we have to do is we have to formulate the RNA with lipids. And these lipids are typically cationic, positively charged. They bind the negatively charged lipid. They either wrap around the lipid or the lipid wraps around them, depends on which system you're using. This both stabilizes the RNA, but it also means that when you inject it into the body, these lipid nanoparticles will carry the RNA to the lymph nodes or to the dendritic cells, and will fuse with the membrane of the dendritic cells and deliver the RNA into the cytoplasm of the cells. Once the RNA is inside the cytoplasm of the cell, it will be translated. So this is using the full protein production machinery inside the cells. It gets translated, as does any mRNA inside the cell, to a protein. That protein is then either secreted, in which case it will induce a B cell response, or it will be expressed in MHC1, MHC2. We get a good antibody response, T helper response, and cytotoxic T cell response. And what's great, it's seen as if it's a pathogen, but it's not pathogenic. Now, the other great thing is that the body has learned to recognize RNA as belonging to a pathogen, so it enhances the immune response. So a really great technology. We don't yet have any vaccines other than COVID using this technology, but I think in the years to come, we're going to see all of the viral vaccines can be made using RNA, and even things that we previously have not been able to make, like HIV vaccines. Perhaps RNA will allow us to make HIV vaccines. So where are we now with the preclinical and clinical development of these? So as of last week, there were 200 and something candidates that were in development. 182 were in preclinical development, meaning that they're still either on the bench or in animals. And 79 candidates are in clinical development. This is absolutely amazing. Just think, we've only been in this outbreak for a year, and we already have over 200 candidates, of which more than 80 are in clinical development. And we've got now, I'll get to this slide. Okay, it's a slide we'll get to in a moment, shows how many of them are already approved and are being used in the population, which we've got quite a lot. I do want to point out, just in this slide here, about whether we give a single dose or 2 doses. Now, this is quite important because you will have seen, those of you following the literature, the newspapers, that recently one of the manufacturers said, our vaccine works with just a single dose. And then others are saying, well, we give 2 doses, but we can see that after a single dose, we're already getting good immunity. Well, if we're getting good immunity after a single dose, why are we giving a second dose? So just a little bit of fundamental immunology here. When you inject something foreign, the immune response is developed to get rid of the foreigner, okay? Now, if you give a second dose, typically what gave us the first dose will now be boosted. That's why the second dose, we often call it a booster. But if you've still got some antigen floating around in the body from the first dose, then the body doesn't realize that this second dose is a real booster. What you really need to achieve what we call the immune maturation, where the system really matures is that there should be as little immunogen from the first immunization left in the body. So the bigger the time between the first administration, the first injection, and the second injection, the better your immune response is going to be, because it's going to be less and less of the immunogen from the first injection. And this is exactly what we're seeing now with those vaccines where we've tested the different time periods. So in this graph on the right, you can see the interval at less than 6 weeks, 6 to 8 weeks, 9 to 11 weeks, or greater than 12 weeks. The longer the interval between these two administrations, the better the immune response. This is not surprising. We've known this for 50 or 60 years, that the longer the time between priming and boosting, the better. But that's a caveat to that, because if you need that second boost to give you the full protection, then you are going to be suboptimally protected between the first and the second. So just bear that in mind. I wanted to put that slide in just to help you understand all of the discussion around 1 dose or 2 doses, and should it be 2 weeks, 4 weeks, 6 weeks, 8 weeks, or longer. The longer the time, typically the better immune response, but during that intervening time, you are not optimally protected. And then recently, one vaccine giving very good immune response after a single injection, but emphasize, but we do not know how long that immunity is going to last from a single injection. And as I said at the beginning, sometimes a second injection not only creates a boost, but it creates memory, a better memory than a single injection. So this is something we still need to examine. But very quickly, these are the candidates that are in clinical trials or that are approved or in phase 4, the post-approval trials. You can see lots of them there. I'm not going to go through this in detail, but I'm going to talk just for a moment about the variants. You all have seen that currently there are variants that involve mutations to the gene for the spike protein. And some of these have been reported to reduce efficacy to protect against mild to moderate disease in people infected with the variants. So this is what people are saying. We think that the vaccines protect against severe disease, but we suspect that some of these variants might be bypassing the protection from mild disease. Now, why this difference between mild, moderate disease and severe disease? These variants are going to be bypassing, if anything, they're going to be binding, there'll be less neutralization by the antibodies, but there's still probably going to be neutralization by the T cells. And so this means we've got to look, and we can't say all vaccines are going to be affected to the same extent. So for example, vaccines that use the full spike might be less affected by these mutations than vaccines that just use the tiny tip of the spike, what we call the receptor binding domain. This is a tiny part. So if you've got a mutation in the receptor binding domain, the vaccine that uses this might be affected by that mutation, whereas it wouldn't be affected by a vaccine that uses the whole spike might be less affected, and a vaccine that uses the whole virus might not be affected at all. But then on the other hand, we've said the whole virus doesn't induce a very good T cell response. So, and we know T cells protect as well. So this is why we've got to be very careful making any statements to say, oh, that mutation very bad is going to reduce the effect of the vaccine. Which vaccine? And is it against a mild disease or infection mild disease or against severe diseases? And what people are working on to overcome this are multivalent vaccines, on vaccines that target multiple sites on several viral proteins, and even some people are trying to identify the common denominator which doesn't mutate, the so-called universal vaccine. So, Sarah, has Maria joined?
She has indeed.
She has. So I'm going to pass over to Maria.
Great. Welcome, Maria. Thank you so much for joining us. I'm sure you actually need no introduction to the folks on this call, but just in case, Maria is the technical lead for the COVID-19 response, and we're very happy to have you here today with us, Maria. So over to you.
Thank you so much, Sarah and Martin. What a wonderful presentation. I could listen to you for days. You're just such a wonderful presenter, and I learn something every time I hear you speak. So unfortunately, now you all have to listen to me. But thanks for the invitation to join this EPI-WIN seminar today. So as you can see on the slide, the world has started vaccination, as you well know. As of a few days ago, as of the 8th of March, almost 350 million vaccine doses have been administered using different vaccine platforms. And you've heard Martin give an overview of the different vaccines that are available. You can see on the graph here that there is quite some variation in the distribution of vaccines and vaccinations that have reached different populations, with Israel vaccinating much of its population. And you can see some examples of countries there. WHO now has a dashboard that not only includes the number of cases that are reported to WHO in absolute numbers, but also by population. We also report on the numbers of deaths, and we report on the numbers of vaccine doses that have been administered. And we pull data from a number of countries, as well as data from our world in data. Next slide, please.
Martin, can you shift the slide?
Sorry, that's me. Sorry.
Thanks, Martin. We'll work on it. It's like our first seminar in the middle of this pandemic. Thank you very much, Martin. So there are a number of studies that are underway looking at the impact and the efficacy of vaccines and the different vaccines and vaccination that are out there. A recent study showed 2 doses of the Pfizer-BioNTech vaccine prevented 94% of symptomatic COVID cases, 87% of hospitalizations, and 92% of severe disease. And this was among almost 6,000 people who were vaccinated towards the end of last year up to the 1st of February in Israel. We do have also some preliminary results in Scotland showing that 4 weeks after the first dose of the Pfizer-BioNTech and Oxford AstraZeneca vaccines were administered, the risk of hospitalization from COVID-19 fell by up to 85% and 94% respectively, showing a combined effectiveness for people over 80 at about 81%. But as you know, most of the studies that are underway are looking at the number of infections, and they're also really looking at severe disease and death, preventing severe disease and death. Next slide, please. In terms of the global vaccine allocation, this is guided by public health objectives. And for the initial phase, the objectives are to reduce mortality. We know that infection with the SARS-CoV-2 virus can be severe. It can cause severe disease, not only death, but severe disease, and people who are at risk for that. So these are people who are over 60 years old and those who have underlying conditions. And another objective is of the first phase of the vaccination plan is to protect health systems. So to maximize the public health impact, knowing that we have a limited supply of COVID-19 vaccines, the global vaccine allocation mechanism targets, number 1, high-risk groups. So these are people who are over 65, people with cardiovascular disease, cancer, diabetes, chronic respiratory disease, or who are obese. And this is specifically to reduce severe disease and mortality. Also to protect health workers and protect the health system, because we know health workers are at a higher risk of exposure and therefore a higher risk of infection due to the nature of their jobs. These groups correspond to about 20% of the general population, and the first phase of vaccine allocation is therefore focusing on vaccinating 20% of a country's population. Next slide, please. You need to keep in mind, though, that we have limited supplies. I'm sure I don't need to tell you that, but by having limited supplies, we really need to maximize the impact by targeting the high-risk groups. WHO makes recommendations in prioritizing groups based on the SAGE prioritization roadmap, and they recommend focusing on at-risk groups to be vaccinated first. And these are people who are older, are persons with underlying condition, and those who are in the health workforce. And this is primarily focused to reduce severe disease among these populations, to relieve congestion on the healthcare system, because we know when a healthcare system is overburdened, the mortality can increase because health professionals are not able to provide adequate care because of the sheer volume of patients that are in hospital. Beds are full and systems become overwhelmed very quickly. It's also in order to leave easy access for the entire population in need of healthcare that's not related to COVID-19, those beds that are required for other diseases beyond COVID-19. And of course, ultimately to reduce mortality. But one of the things, if you've ever heard WHO speak, you know that we talk a lot about all of the different measures that one can take to prevent infection in you, but also to protect your loved ones. And it's the combination of factors, including public health and social measures at the individual level, at family levels, communities, societies, governments, nations, as well as globally, we all need to take to reduce the spread. Vaccines, and more importantly, vaccination, is an additional powerful tool that we have in our toolbox. And in the Strategic Preparedness and Response Plan in 2021, we have now added vaccination as an additional powerful tool to help reduce, to prevent as many infections as we can, reduce the spread, reduce severe disease, and reduce death. Next slide, please. I think this is the last slide, just showing an illustration of all of the things that everyone needs to consider every day about keeping you and your loved ones safe. Everywhere you go, when you leave your house, know what your risk is of exposure and take measures to lower that risk. So keep your distance, wash your hands frequently, cough and sneeze into your elbow. I should tell you, my 2-year-old, I have a little boy who now every time he coughs and sneezes, he lifts up his elbow and he sneezes into his elbow. And when he forgets, he puts his elbow up and he says, achoo. So if we can teach a 2-year-old these types of behaviors, all of us can do that. Make sure that you have good ventilation in the rooms that you're in, open windows. It's as simple as open windows in many situations, and wear a mask. Back to you, Sarah.
Thank you so much, Maria. We have got a lot of questions that have come in, and so I think what I'm going to do, I know, Martin, you've been scrolling through the Q&A as well, so I will ask if there are any specific ones you would like to address that you've seen, and then go on to some of the ones that we've received in advance of this webinar. Martin, was there anyone that jumped out at you?
Okay, I mean, look, there were quite a few. Just let me quickly jump into two. Somebody asked a question about mucosal immunity. So yes, this would be a great idea. We know that mucosal immunity can have a totally different effect. We know this from influenza, where we've got a live attenuated influenza vaccine. So people are working on it, but we have to be careful. Some people have suggested that the mucosal immunity can also play a role in pathogenicity. Then somebody else said, well, do we need antibodies or T cell? And actually, this is interesting because the antibodies can play a better role in immediately catching the virus and neutralizing it. But if there is a drift, if you get infected with a virus where your antibodies don't do it because they don't recognize the virus anymore, that T cell response can be really important in protecting you. So the answer is both. Sarah, back to you to...
Great, thanks. And so I'm going to read the questions out, and between Maria and Martin, I think we just leave it quite flexible, that you jump in when you feel that this is a question that you'd like to address. So the first question: what is being measured when we state that a vaccine has 95% efficacy? Is it protection against the disease, protection against severe disease, protection against mortality, etc.? What is it that's being measured?
Okay, I'll take that. So most of the time, it actually depends on what the study set out to do. And not all of the studies that you will see reported set out to do the same thing. Some of them say any infection, so PCR confirmed infection, the protection against infection. Some of them, it's symptomatic disease. For most of the vaccines that have also had a secondary endpoint, which is looking at severe disease, the efficacy is greater than 95%. It's sometimes 99% or even 100% against severe disease. So there is no fixed answer.
Thanks, Martin. Can we take the flu vaccine and the COVID vaccine concurrently, or do we have to wait in between?
I think we say 2 weeks, Maria. Can you confirm?
I think that's correct, but I think that's a good opportunity to mention that there are many vaccines that are out there that protect against other diseases, and it's important that we still take those vaccines as well. So flu vaccines, in the beginning, there were a lot of questions around, will a flu vaccine prevent against COVID-19? And the answer to that is no, but a flu vaccine will prevent against flu. And that is really important, because if we have individuals who are experiencing flu or flu-like symptoms, it's very, very difficult to distinguish between the common cold, flu, or COVID-19. And so if there are vaccines that are available against the diseases, vaccine-preventable diseases as well, and WHO has been working really hard to get vaccination for other diseases back online, because they've been severely disrupted during this pandemic. So it is important that we get the vaccines that are available, that are proven to be safe and effective against those diseases.
Great, thank you. Is there any difference with respect to the length of immunity from the different vaccines? Will different vaccines give immunity for different lengths of time? Do we know?
Yeah, well, we don't know. We can predict that they will, unfortunately, but we don't know which ones are going to give a long response compared to other ones. So I'm afraid that it's going to take time to know.
Yeah, and that's a great question. I mean, you know, we are learning, as you saw Martin present, we are constantly learning about what natural infection means in terms of the body's response and antibody response, how strong that antibody response is, how long it lasts, depending on the type of infection, if you had disease, any disease at all, or if it's been severe. But we're also learning about the impact of the antibody response and immunity following vaccination. So even though I think everyone feels like we've been in this situation for years, it has in fact only been about 14 months. And so we will continue to learn. And I think one of the important things is that we remain humble to this virus, because it likes to surprise us in many ways. So we need to follow the science. We need to do the studies, and some of these will just take some time.
Thanks, Maria and Martin. Another question, do we know anything about or whether there might be possible limitations if you receive your first vaccine from your first dose from one particular vaccine and your second dose from another vaccine?
Okay, I'll weigh in and then maybe ask Maria to weigh in as well on this. So we recommend that you receive, if it's a 2-dose vaccine, we recommend that you do try and receive the 2 doses from the same vaccine. We have not yet got data on mix and match, and the manufacturers did not intend that you receive one vaccine and then another vaccine. Now, we could discuss the theory, the immunological theory, which would say probably not that serious, but we don't recommend it. Maria?
No, I think you've answered it, Martin. We don't recommend it, but it hasn't been studied really, to look at the different combinations of vaccine. I know that there is some discussion about this because of limited supply, but I am not aware of any results that have looked at different combinations of vaccines, as well as looking at the timings between vaccine doses. There's a lot of work that's in that area as well. As an organization, we make recommendations on the information that we have, the data that we have, the evidence that we have. There are so many theoreticals that we can consider, but we need to make sure that we're providing evidence-based guidance, which evolves, which grows, which changes. And the SAGE working group is meeting regularly to discuss some of these aspects. But I'm afraid we don't have a clear answer on that.
Thanks, Maria and Martin. Martin, you were talking about the length of time between the doses. Do we have any recommendation for what is the maximum length of time between doses beyond which we begin to see an ineffectiveness of the vaccine?
Okay, so we have recommendations about what the length of time should be between doses. Okay, so for example, we say it should be given no more than X weeks later. But as Maria just said, this is based on the evidence that we have. We've got evidence to show that it works out to there. Now, what happens is if you don't get the vaccine, this is now getting to theory, not evidence. If you don't get the vaccine, it is possible that the immunity from the first dose is going to start declining. But that second dose will always work. So when you get that second dose, you will get an anamnestic response. It will provide you protection. But in the meantime, you are exposing yourself to risk because the immunity from the first dose will have declined.
Thanks, Martin. Quite an interesting question that's come in. One of the participants is living in a country that is quite advanced in terms of rolling out the vaccine. And this person has been told, even though they're not part of a high-risk group or a priority population, they might receive the vaccine as early as May. Given that a lot of countries in the world might not even have started vaccinating their priority populations, there is this kind of ethical concern. Is there some mechanism by which people in these countries where vaccines are being rolled out quite rapidly could donate their dose of the vaccine and then postpone them getting one until 6 months, 9 months down the line?
Maria.
That is a fantastic question. And I think it's a question that all of us are running through our own heads about this. But the answer is, when you're offered a vaccine, you should get the vaccine, because what we don't want is vaccine wastage. We don't want vaccines to expire, because these are a precious, precious commodity around the world. What you can do, though, is you can talk to your leaders and you can talk to your elected officials and say, part of these vaccines that are being used for our population need to be donated. And there's mechanisms through the COVAX mechanism by which this can happen. And so people can have a voice in raising and using that voice for leaders to take action. And so that's what we would recommend. But at the present time, I'm not aware of a mechanism by which you can say, take my dose and give it to someone else, because I know all of us would want to do that. And so that's a really admirable question. And, it really highlights the good people that are all over the world that want to see these safe and effective vaccines, which is an incredible scientific feat to have available, be delivered around the world. As WHO and part of our COVAX facility is that we want vaccines, we want vaccination to begin in all countries in the first 100 days of this year. And we're working towards that. And you've seen many, many deliveries from COVAX. I think yesterday it was 24 countries. I could be wrong on that, but I have to say I was a little teary when I saw some of those planes land in many countries, because this is a tremendous feat, but we have a long way to go. So if you can, use your voice and try to make this a better world by making sure that those countries that have the capacity to make more provide those vaccines to those most at risk in every country. This is what we want to see as WHO and as COVAX.
Thanks very much, Maria. Martin, I think this is a question for you. If you have had COVID before, you have a certain amount of immunity. Is it still recommended to get 2 doses, or would 1 dose be enough?
Okay, well, I don't know what we recommend. I would say, here again, we're going to get into what's the evidence. So we've seen some evidence recently published that showed that actually the second dose, if you've been infected, the second dose was not enhancing the immune response any further. So you are not getting maturation, you are not getting greater B memory cells being produced. However, I want to emphasize this, that some people, when they get infected, their innate immune response is so good that their infection is just transient. It lasts a few hours. Others, you go on to be horribly sick and you're hospitalized for weeks. And so both of you were infected, but you've got a totally different fundamental immune system. So we don't have a mechanism to say, well, you were infected, but you should get 1 dose, and you were infected, you should get 2 doses. So I would recommend, since the second dose cannot hurt, and it could be that you didn't get a good immune priming from your infection, my call would be to say, get 2 doses. Now, this would then come into something Maria's just been talking about. Well, is this using vaccine that you don't necessarily need? I think that it's far better to get 2 doses if you don't know, because currently we don't know whether your immune system primed you. But again, this could be a national decision. It's going to be quite difficult to implement, though, to separate out by those that were or were not. I also want to highlight, a lot of us don't know that we were infected. And there is such a thing as a false positive PCR. So you might think you were infected, but you don't know that you were.
Thanks very much, Martin. We're almost at time, so maybe we'll just have time for a couple more questions, but I will also then hand back to you, Maria and Martin, to see if you have any final comments. But do we have any new data on the transmission of COVID in post-vaccination infections?
That's also a very good question. So there are some studies that are underway that are looking at the risk of infection among people who have had one dose and also after that second dose. And so those are studies that are underway, and we know that people can get infected between the first and the second dose. I'm not sure how well that has been quantified yet, but we know that that's possible, and I think that's important. So it is important that we still adhere to all of these measures as vaccines and vaccination are rolled out. In terms of how vaccines are going to impact transmission, most of the studies that are underway are really focusing on an endpoint of severe disease and death. They haven't actually measured yet the risk of onward transmission. Having said that, we do expect that there will be some positive impact on those who are vaccinated in terms of reducing transmission, but we don't have that complete picture yet. So again, it is important that people adhere to the measures that are in place in the areas where you live in a precautionary way to make sure that we take all of the steps that we can to limit the spread. Martin?
So you know far more about this than I do, so I'll leave it to you.
Thanks very much. Perhaps one last question, and that was really with regards to the follow-up of vaccinated people. Is there a central mechanism whereby the data is being pulled so that we can understand these questions around the length of immunity, the effect of transmission, and what's WHO's role in that follow-up?
Okay, that's a very good question.
A huge question.
It's a huge question. Maria, do you want to answer first? Because
only to say that we have many networks that have been established to look at this. So WHO, one of our superpowers, if you will allow me, is our ability to convene the world's expertise on a number of different topics. And the current pandemic is no different. And in fact, because everything is virtual, we've been able to actually expand our networks and bring more people together to try to answer these critical questions. What we're currently trying to do with all of our networks that evaluate the epidemiology, the spread, transmission, the impact of vaccines, is to incorporate available data as it comes out. And I have to say, full studies, not press releases, because most of the information we get, unfortunately, is first in a press release, which on one hand is wonderful because we get the information up front, but that's not the same as having a full study and really understanding how each of these studies were done and looking at the data and assessing the quality of each of those studies. We work through our international networks to consolidate the evidence and turn that evidence into guidance. And we do that through many different mechanisms of really robust external and internal review in terms of how we generate that. And then we turn it into practical advice to our member states, to ministries of health, to decision makers, to medical professionals, and to all individuals. So it's a very long, complicated question, but it's an iterative process. I mean, we are literally talking with thousands of scientists and public health professionals and medical professionals every day, which is a wonderful way in which we can exchange. And so when we have that information, we discuss it, we kick the tires, if you will, and challenge it. And then we see how our current guidance on a topic should or should not be modified. And if it needs to be modified, how? And then we go through a review process. Now, all of that is expedited in a pandemic, and we're working as fast as we can to get that information out. And we find different channels in which we can disseminate. The EPI-WIN platform is an excellent example of getting information out to various audiences, because we have a lot of PDF documents that are our guidance, but that's not the same as actually reaching many different groups around the world, professional organizations, individuals, religious groups, interested people all over the world. So we try many different ways to disseminate that, but it's a constant process by which we're trying to feed in evidence, practical application, experience, and then feed out the latest updated guidance. Martin.
Oh, I mean, that's great. Marie and I were discussing who takes what. I love the molecules and the cells. I leave this multicellular stuff to Maria.
Sarah, I'm really, really sorry, but I have to run to another meeting right now.
Yeah, we're ending it. So thanks so much, Maria, to both you and Martin. I think you make a great team, and to everybody online. Again, thank you for joining in, and look out for the invite for next week. We hope to be addressing some of the travel related questions around COVID. So that will be another very interesting one. But just Martin and Maria, thank you. We've called on you, we've taken your time, and it's just always a pleasure to have you. So thank you to you all. And
thank you so much.
For joining. Okay,
Bye.
take care, everybody. Bye-bye.